This is part 3 of chapter 1. All right, now the next thing we're going to talk about is on page 12, table 1.1. It's the different ways drugs get into the body. Now you kind of need to know the different routes because this is very important because this is how you're going to be given your medication. So the first one we're going to talk about on the top is the percutaneous route. Percutaneous, this is from the skin or the mucous membranes, so it's going to be from the mouth, the nose, the lungs, the lowest 1.5 inches of the rectum, and also it's considered the vagina. Okay, so that is your first route, your percutaneous. Now your second one is your enteral route. This is the one that you're going to be giving the most of, enteral. It is the one that's dealing with the GI tract. So we give it by mouth, or a tube in the stomach, or the rectum, the higher 1.5 inches. So the lower part is percutaneous. If you go higher than 1.5 inches, then it's considered enteral. Okay, this, like I said, this is where we're going to give most of our drugs. This is where the meds are going to dissolve in the GI tract. This is where we're going to give higher doses because it doesn't all reach the bloodstream. It does not give you that 100% bioavailability because a lot of it isn't going to reach the bloodstream. It's going to get excreted out of the body. So like I said, it's less bioavailability. A lot of times if you eat it with food, it can cause issues with absorption. Diarrhea, if you have diarrhea, it's going to make the medication get eliminated quicker and not stay in the system longer. It's not a sterile route, so we do not need to use sterile gloves or anything like that. So that is going to be the most strength. So far we talked about the percutaneous, and now we talked about enteral. Now the last one, the third one, is parenteral routes. These are anything that we inject into the body. So parenterally, I think of the parent, we're going to inject. They want their injections into the kid. So I always think of the weird things sometimes. But parenteral route, that's injections. You inject into the body. It will go directly into the bloodstream or a targeted tissue. Now, of course, bloodstream is going to be intravenous or IV. Targeted tissue would be intramuscular or sub-Q. It does not go to the GI tract or the liver. On page 13, if you want to go to page 13, let me look on my book here. You can see the parenteral routes, the different types of parenteral routes, but they're all injectables. Okay, those are the examples. They work quicker than giving it either oral, the enteral route. They're 100% bioavailability, especially the IV, and it's more invasive, so you can have more complications with it. And usually with these ones, the drugs will be sterile. We have to use sterile technique when handling these meds and when we give these medications. So parenteral route, that is the one everybody loves because they get to do the injectable parts. All right, so those are the 3 different routes that you guys need to know, the different routes of medications. Now, distribution. Distribution is how the drug travels to get to the targeted cells. It does this by the blood. It works on the plasma volume, the interstitial spaces, as well as intracellular spaces distribution. So how it distributes throughout the body once it's given. Now, trapping of drugs. Drugs do get trapped in certain areas of the body and will hang out. This is called sequestration. Okay, it will stay in the body longer. For example, fat cells will hold onto certain meds longer and they will not get rid of them. So they get trapped in a certain area. Now, metabolism, on the other hand, any drug we take, our body considers it foreign. In order to get rid of the drug, we have to metabolize it in order to get rid of it. So the body will change the structure of the drug. It will start breaking it down. This allows us to inactivate the drug and get rid of it easier. Some drugs get activated and do what they were intended to do. Then it gets metabolized and again to be deactivated for elimination. Drugs metabolized in the liver, kidney, lungs, and the white blood cells. So that's where we metabolize drugs, in the liver, kidney, lungs, and white blood cells. The liver and kidneys are where the majority of your metabolism is going to happen. If you have issues with them, it can lead to problems. It can lead to drug toxicity, And the majority of the time, if you have any problems with your liver and kidneys, they will prescribe lower doses of medications for you, because if we give you high doses and you're unable to metabolize those medications out of the system through the liver or kidneys, then you're going to become toxic and have those adverse reactions, and it could even lead to death. So that's why we have to be very careful with our liver and kidneys, because those are the two major areas of elimination and metabolism that occurs. So we want to make sure we want to watch those patients very closely. Now, when we talk about elimination, that means we're removing the drug out of the body. Usually the route will be the intestinal tract, we can poop it out. The kidneys, we can urinate it out. Or the lungs, we can breathe it out. Okay, so those are the routes that we have for elimination. Now, the drug leaves the body, like I said, by the stool, the urine. You can exhale it, actually sweat, tears, saliva, and breast milk. So that's why a lot of times women who want to breastfeed, if they're on certain medications, they do strongly recommend that they do not breastfeed, because they can actually transfer that medication or drug to the infant and cause issues for that infant. So that's how the drug leaves the body. A lot of times it is metabolized by the liver and also the intestinal tract or blood. The parenteral drugs, injectables, are eliminated by the intestinal tract. Oral drugs, some drugs get metabolized fast by the liver, and some get eliminated quickly. It's usually called the first pass loss thing. So that's one thing that happens. This is why oral drugs, enteral drugs, are less bioavailable, and the doses are higher compound compared to IV meds. So a lot of times you will see that if we give something oral, it will be a higher dose than if we give it intravenous, because we need a stronger dose, because a lot of it isn't going to get to this areas that we want. It's going to get eliminated quicker. Now, if we give it IV, it's going to go faster and get to that system faster. Some drugs dissolve in the blood and is eliminated in the urine. Sometimes urine can have a certain color or smell because of that. That is how we can test for illegal drugs. So people who think that they're going to, do some, opioids, certain narcotics that they're not prescribed, it will actually get eliminated through the kidneys. And then what happens is they'll do tests on the urine, and that's how they determine if you have any illegal substances, because you excrete it out through your system. Sometimes it's not uncommon to have certain smells or colors. It's very thing for people who eat asparagus. They can have that smell when they urinate. It's a certain enzyme that occurs. Some medications will actually cause your urine to turn orange in color. And we'll be talking about some of those medications throughout this thing. Then the drugs can leave by the lungs through vapors. This is how we actually check for people who have drank too much. We do alcohol levels by doing a breathalyzer. We have them breathe into a tube, and it senses it that there's alcohol in the system. So that's a way that we excrete drugs out of our system, is through the lungs. But our liver and our kidneys are the two most important ways to eliminate drugs. If you have problems with one or both, it takes longer for the drug to be removed from the body, which can build up toxic levels. You can have hepatotoxicity, which is liver damage, and nephrotoxicity, which is kidney damage. Many drugs can cause just liver problems, some can cause kidney damage, and some can actually affect both the liver and the kidneys. But we do need to monitor that very closely, and that's going to be the most important thing we're talking about in these chapters, liver and kidneys. And when we're talking about livers, we're going to be checking those liver enzymes, liver function test. If we're talking about kidneys, we're going to be checking the BUN and creatinine levels. We're going to be doing urine studies. People who have, there are some people who have deficiencies of enzymes that can actually make it harder to eliminate drugs. And this can actually cause toxic levels in the body. So that's something that they, have to consider also. All right. Now, the next thing we're going to talk about on page 16 is half-life. Half-life, this is the time it takes for half of a single drug dose to be eliminated from the body. okay? And it's on page 16. Let me turn my page here. And there's an example of it, actually, okay? So the half-life of a certain medication. So it is the half of a single dose to be eliminated from the body. The drug is considered eliminated when less than 10% of the drug is remaining. Half-life is related to how fast drug is eliminated. Drugs that are eliminated fast have a short half-life. Drugs that are longer to eliminate have a longer half-life. Half-life is based on research. Okay, it helps prescribers order the correct dose and how many times a day to balance the intake with elimination of the drug. So it's order for us to maintain a certain blood level. We want to keep a certain beautiful blood level. So that's why it's important to know what the half-life is, because that is going to determine how many times a day they're going to take it, what the strength they're going to take it, because it determines elimination process. Half-life will differ for certain groups. For example, patients' age, size, gender, race, metabolism, genetics, health, and other drugs can actually make the change in half-life. Short half-life is given more than once a day to maintain a therapeutic effect. So if it's a short half-life, we're going to give it more often. If it's a longer half-life, the first dose is usually a large dose. We call it a loading dose. Okay, so the first dose would be a loading dose. So we would give probably double the amount, just to give the boost to the body, and make sure that we get that medication in the blood and get that level up. Then the following doses will be smaller because the drug will take longer to eliminate. Okay, so that's basically half-life. So when we're dealing with half-life, and it's dealing with this chart here, okay, it says time needed. So we know that this single medication has a half-life of 6 hours. So when you first give it, the doctor ordered it at 500. So every 6 hours, it's going to be half of that amount. So half of 500 in 6 hours, there's 250 milligrams in the system. And so 6 hours later, that's 12 hours from when you gave it, it's 125. So on and so on and so on until it's completely eliminated. And we consider that less than 10%. Now, when we're dealing with half-life, you also have to remember every time you take a pill, that's another medication that you're adding on. So that's like, so if you decided you have a 500 and then 6 hours later you have to take another 500 pill. So now you have a total of what? 750. I just hit one of the kids' toys. 750 milligrams in the system. So then you have to deal with 6 hours from that. The other one is going to be at 125, the first pill you took, and the second pill is going to be at 250. And then 6 hours from that. So you have to consider when you add more pills on, that level of milligrams will go on, and the half-life will be different. And if you have any problems with that, talk to me personally so I can explain it a little better if you're not understanding what half-life is, because there will be questions on half-life and how to, figure those out. So I want to make sure that you understand half-life. All right. Next thing we're going to talk about is peaks and troughs. Okay, peaks and troughs, and this is on page 17. Now, peaks is when the medication is at its highest, it's the peak. And then the trough is the lower part. It's like that scoop that you see on page 17 in that little diagram. It's the lower part. Now, the relationship between the actual dose of the drug given and the blood drug level over time, that's what peaks and troughs are. And like I said, peaks are the maximum drug level in the blood. Trough is the minimal drug level in the blood. Example that we do peaks and troughs is vancomycin, and it's a lab work. Usually 30 minutes beforehand, they would want to get a, what would you think? They would want to get a trough level when the drug is at the minimal amount. Then after we give the medication, the doctor may want to get a peak level. And the peak level we would do 30 minutes after we give the medication because that's where it's at its maximum peak. Okay, so usually 30 minutes to an hour, they'll want to do a peak and trough level. This helps determine the doctor, do they have the correct dose? Is it staying in the system where they want it? So peaks and troughs a lot of times. So if you have an order for a peak level, okay, then you would do that after the drug. You would wait 30 minutes to an hour, and then you would have lab drawn to see what the level would be in the system. If you're doing a trough level, you would do a trough level 30 minutes before the medication is due. You would wait for that lab value before you would actually give the medication because the doctor may want to change it. But trough levels are done before and peak levels are done after. Okay? And usually, like I said, vancomycin is the drug that they usually do it for. Now, the next thing we're going to talk about is lifespan. Lifespan considerations, these are dealing more with like size, organs, and things. So when we're talking about lifespan, we're talking about the size. Children we know are smaller and the dosage of meds are going to be smaller and it's going to be based on weight. And we know that 1 kilogram equals 2.2 pounds. We always should double check the doses with another person when we're dealing with the pediatric population because even a small point off could actually harm and kill a child. So that's why it's very important to always double check pediatric doses. If it feels like the med dose is wrong, then question it. Compare doses with the recommendation for the drug. Another thing when we're dealing with children is children get a lot of paradoxical effects, and you kind of need to know paradoxical effects. Paradoxical effects are opposite reactions to what the medication happens that an adult takes. For example, some drugs will make an adult very tired. An example of that would be diphenhydramine or Benadryl. It will make an adult tired, but if you give it to a child, they will be bouncing on the walls. They will be hyper and running all over the place. So that is called a paradoxical effect. It is the opposite reaction that is occurring when you give a drug. It's not what you expect to happen. Drugs can interfere also with the growth and maturity of children. Example, tetracycline we're going to talk about. Tetracycline interferes with the density of tooth enamel and will actually cause teeth to become dark. So it is not to be given to pregnant women or children under the age of 12 because of that. Another thing is quinolone antibiotics. We do not want to give them to children because it can actually damage the bone growth. So lifespan and the size of it in children, it's very important that we make sure that we watch them very closely. Now, when we're dealing about organ health is another thing we're talking about is the liver. The liver is needed for, I told you, drug metabolism and elimination. And on page 18 are some lab values that we need to know. Okay, so that is the labs that they're looking for when they're dealing with liver functions. I don't expect you to know the values for those, okay? You do not have to memorize them. Just know what's in a liver function test, okay? Premature infants or newborn infants are not fully developed, so their metabolism is going to be slower, so their livers are not fully developed. Toddlers up to adolescents have higher rates of metabolism than adults, so they may get smaller doses, but they might be getting it more often. In older population, the majority already have liver issues because they've used them over time, so a lot of them do have liver damage due to time, so metabolism and elimination are going to be slower. So a lot of times we will give them lower doses of medications. Liver function decreases as we age. Older adults are at risk for drug toxicity, so we may see them order lower doses, like I said. All right, I'm going to pause it here, and then we will be back, and we will do the next set on this thing. So I will return.